Good morning. Is this mine?
Thank you, Sherry. It's my great pleasure today to introduce the speaker, Dr. James Whittle. He's a member of our club and a distinguished cardiologist with decades of clinical and academic experience. Dr. Whittle graduated from the University of Florida College of Medicine 1980, where he also completed his fellowship in cardiology. He's board certified in by the American Board of Cardiology, Internal Medicine, both certifications. Yeah. During his career, Dr. Whittle was among the early pioneers in cardiac catheterization and gained an extensive experience in a wide range of cardiovascular procedures. He also participated in the National Institute of Health study evaluating outcomes in what is now called interventional cardiology, at a time when the field was still in infancy. Today, Dr. Whittle will present a history of the heart from the cave to artificial intelligence. He will guide us through the remarkable story of how medical pioneers from the Renaissance to the present day have sought to understand the human heart, revealing its secrets and transforming how we diagnose and treat heart disease. He will also explore how the heart continues to inspire innovation and wonder in the era of artificial intelligence. So on behalf of the History Group of the University Club, please join me in welcoming Dr. James Whittle. James?
Can everybody hear? Let's see. It's on. Can anybody hear me now? Let's see. Is that any better? Good. I see Manuel's back there tweaking things a little bit. Before we get this set up, can you hear me better now? I wanted to also mention, I'm going to mention Ovid's name in this a couple of times, because as we were getting this set up, I found out that Ovid knew several of these people, which amazed me. Let me see if we can, let's see. See if it's going to, yeah. Let me go back. Let's see. Manuel, I'm having a little trouble. Let me turn it off. If you could help me just a moment. Let's see. Okay. Let's go back one. Yeah. Can we go back one more? There we go. First of all, does anybody recognize these guys? Okay.
That's me.
Yeah. Actually, it's Roger and I both back when we had hair. Anybody recognize this guy? Ben Casey. Remember the start of it? Man, woman, birth, death, infinity. And Sam Jaffe did that. And this guy, Richard Chamberlain. I was 15 years old at the time, and I've been a nerd my entire life. And I will be until the day I die. And as everyone that knows me can attest to. But anyway, I started watching these guys when I was 15 years old, and I was hooked. I thought, that's neat stuff. And I was into science and math. And so I decided I'm going to go to medical school. So I did. And then my first week in medical school, Dr. Moss Hara died, who was primarily a pediatric cardiac surgeon, died, and we had to go to a memorial service for him. And the speaker was Denton Cooley. And I think, yeah, there we go. And those of you who may not be familiar with him, he was a protege of Michael DeBakey and actually outshined him in many ways. And during this talk, he talked a lot about repair of congenital heart disease, and I was hooked in, hook, line, and sinker. And I spent the rest of my life pursuing that. Now, I'll get over here. The next thing I need to do is to give you a little bit of basic anatomy so that you know what we're talking about. This is what we know now, that blue blood or unoxygenated blood comes into the right atrium, into the right ventricle, into the lungs, goes through the lungs, back into the left atrium, and then into the left ventricle. The other thing that's important are these coronary arteries, disease of which results in heart attacks, chest pain, and things of that nature. So it wasn't always known about that. This is just an example of a close-up, more of a tricuspid valve here. And what we're going to talk about is what we didn't know, what we thought we knew, and how this has evolved over the years. Now, nobody came out of a cave holding a heart and said, this is how it works. Now, is this, we know it's not a real photograph of a caveman. Is this artificial intelligence or is this a painting?
Artificial intelligence.
How do you know that?
It's just too good. Yeah.
Well, I think it's because, let me go back. He's got an earring. And I don't think cavemen had earrings. But at any rate, now, this is not what the heart looks like. The heart is about the size of your fist, and it's not heart-shaped. And one of the early adaptations that was the heart was labeled with was a silphium seed back in the 6th century BCE. And this was a spice, but it also was unusual because it was both an aphrodisiac and birth control, which I thought was an interesting combination. But many years later, Hippocrates said it did not cause flatulence. So I was quite happy with that. This is not what things look like. One of the first inclinations of the heart is from a cave painting in Spain. And it's interesting how this heart looks like the silphium seed. But what they think it may have been actually was a target where to shoot the animal to kill it so they could eat it. Anybody know what kind of animal that is? No? Woolly mammoth. And I did not realize that they coexisted at the same time. But anyway, that's what they knew, that if you shot an arrow there or a spear, you could kill the animal. And then in 2600 BCE, many of you may be aware of the Epic of Gilgamesh, which was one of the first recorded texts. And if you look at it, it's pretty racy. But at any rate, what he noted was his friend who had died said, "You have turned dark and do not hear me, but his eyes do not move. He touched his heart, but it no longer beat." So maybe there's some association between life and the heart. but no one knew what it was. One of the other things that happens is when we die, we reach ambient temperature. So you get cool. And for many years it was thought that the heart was the furnace and that blood got into the heart. It kept us alive by keeping the heat up. Now, if we go back to the Egyptian Book of the Dead, when the Pharaoh died, the heart was taken from the Pharaoh along with the other organs, but the heart was kept separate. And then the heart was placed in a jar and was weighed by the god Anubis against a feather. And if the heart outweighed the feather, you couldn't get into the afterlife. And the sins and transgressions of the Pharaoh were transferred to the heart and weighted it down. And if you were bad, you couldn't go forward. And this was an inscription from the Book of the Dead. "O my heart, which I had from my mother, O my heart, which I had upon earth, do not rise against me as a witness in the presence of the Lord of things." This was for the pharaohs, not for the people who built the tombs and did everything else. Now, what they thought was that they would place a scarab on the chest of the pharaoh, and that would guide his heart into the afterlife. But one of the things I found interesting is, while the Egyptians envisioned his heart ascending to heaven on the wings of a gilded beetle, the Israelite was more likely to picture as a stony repository of shame, obligation, and lamentation. And I found that kind of interesting. Now, getting more towards current times, in 400, Hippocrates thought that diseases were not caused by the gods and the soul resides in the brain. But then 100 years later, Aristotle said the heart is the central organ. And the reason that he knew that was he looked at chick embryos forming, and the first organ that formed was the heart. So he thought that was the beginning of life, and he thought that the soul resided within the heart. Now, this is a Greek physician that I never heard of, Herophilus, and this was in about 300 BCE, and at that time he was doing dissections of humans, but he also did vivisections while these prisoners were alive and looked, and he began to identify the anatomy better, but had no idea about function. Then things went dark. During the Dark Ages, with the Spanish Inquisition, knowledge of the heart and so many scientific things were gone. Then, and you'll have to excuse my duplication, along came Leonardo da Vinci, that I think is probably one of the brightest human beings that has ever lived. And he started doing dissections of the body. Michelangelo did dissections, but primarily was interested in the muscle and the bones so that he could present the way people moved and their anatomy better. But Leonardo worked hard on trying to define the anatomy, and this is one of his drawings showing a tri-leaflet valve. This is the right atrium, left atrium, coronary arteries, and it's incredible what he identified. And does the writing look kind of funny?
It's the other way around.
Why?
Right, left.
Why?
Right to left.
Well, that's exactly right. And there may be a couple of reasons for that. First of all, his drawings of the heart were not discovered until 250 years after he died, which gets into the time we'll get into in a moment. But he used what's called mirror writing. And you're totally right. And in mirror writing, it's all backwards. He may have been trying to hide what he was saying, but he was also left-handed and didn't want to smudge the paper. So, you know, who knows, and we'll never know. There was another Italian physician named Rialdo Colombo that in 1559 established the fact that blue blood came into the heart, got pumped into the lungs, and then red blood came out of the heart, came back into the heart and got pumped out in the rest of the body. This was a big deal. One of the earlier physicians that's well known, Galen, had said that there were holes between the two lower ventricles, and that's where blood got across, and somehow magically it got oxygenated. But once the microscope was invented, they discovered capillaries. So then we had the full circuit of the flow of blood described. And then along came Sir William Harvey from England, and he began to describe the incredible circuit of blood from the heart into the lung, back into the heart, and pumped it out. And a lot of his experiments he did were so simple, but were incredible. Like putting a tourniquet on the arm and seeing the vein swell. Well, that means the blood's coming from down here up there. If you put it on too hard, the hand gets white and cold. That's where the artery's going. And it was remarkable what he had done. Now, he met an interesting young man named Viscount Hugh Montgomery. And he was as a late teenager, he was riding a horse. The horse tripped and he fell on a sharp rock. That opened his chest, and miraculously he survived it and it healed. But you could look in and see his heart, and you could feel his heart. And that began to define better the upper chamber and the lower chamber working together. And anyway, he presented this to King Charles I, and went on from there. But it was quite a thing. And later, when I taught medical students, what I used to do was to put a tongue depressor over where you feel the heartbeat, and you could see that motion. And that was back in the olden days when we did physical examination. Now, René Laennec decided we need to hear the heart better. So he invented the stethoscope, but it looked like this tube. Why did he do that? Anybody? He wanted to hear, but also think about modesty in that time. Nobody wanted a woman to open up and reveal herself so someone could put their ear on her chest and listen to the heart. And this was actually a privacy issue. Now, in 1903, Wilhelm Einthoven developed a way of measuring electrical current using what's called a string galvanometer. And with that, he was able to record the electrical activity of the heart. And he used the term, being Dutch, electrocardiogram, EKG. That's why people still call it EKGs from the Dutch. We always used to call it ECGs, but EKG is a common use because of that. And this is what it looked like. This is Eindhoven. This is him sitting in saline baths to record this EKG. It's gotten a little bit simpler now. And you can order these from Amazon. What was it, $69.95 or something? And anyway, it's gotten a lot simpler. But this began to open things up. And then, man, it exploded. This is Werner Forsman, who was a urologist and Ovid met, and which I was impressed with. He decided he was going to do a catheterization on himself. So, but he told his nurse he was going to do it on her, but just at the last minute, he took a scalpel, opened up his antecubital fossa, found a vein, stuck a catheter in it, and the nurse thought he was crazy and even turned him in as being insane. Anyway, he threaded this catheter up into his heart, walked up 2 flights of stairs, and got an X-ray. And it was, he said it was very painful. I felt I'd planted an apple orchard and other men had gathered the harvest, stood at the wall laughing at me. But in 1956, he shared the Nobel Prize with Kernan and Dickinson Richardson. Now, anybody ever heard of the Cleveland Clinic? Well, this is a guy named Mason Sones, and I'm going to tell you right now, you'll have to excuse my language. Mason Sones first did a catheterization and injected dye into a coronary artery by accident. And what happened is he used what's called an NIH catheter and was going to inject above the aorta in this area, but by mistake or by accident, the catheter dove into the right coronary. When I was first learning catheterization, that's what we referred to as an oh shit moment. And because if we tore the artery, we couldn't fix it. But gradually, he began to change this. But also, among his instruments on his tray was a very small clamp called a mosquito clamp. And what he used that for, he used it to hold a cigarette so he could smoke while he was doing catheterization. But these films were made subsequently on 35 millimeter film. And he needed to be able to stop the film, run it backwards, run it forwards, and there was no projector except for one. Anybody know who Paul Brown was? John? He was the coach of the Cleveland Browns. And they had a projector that would stop and start and go back and forth. And since they both were in Cleveland, he borrowed one of these and used it for stop action. And so NFL does have a place in medicine. And anyway, now we can have very high quality injections. This is the left coronary artery, the left main, the circumflex, the LAD, and then this is the right coronary artery. Now, how can the heart break? Well, one, you can have plumbing failure. If the plumbing gets clogged up, it causes coronary disease and heart attacks. You can also have electric failure, and I'm not going to really spend much time on these other two, or it can just break. Now, in 1506, I think this is a beautifully stated thing. Leonardo da Vinci observed an old man that died suddenly. And he wanted to find out why did he have an anatomy to discern the cause of a death so sweet? And what he found was that the coronary arteries were thickened and obstructing, and he thought that was the reason that the patient died. That was in 1506. And now we know, thanks to Mason Soanes and his work, this is a high-grade lesion in the mid right coronary artery here. There's one there and one there. This is in the artery on the front surface of the heart. Anybody ever hear of the Widowmaker? This is the Widowmaker. And so what he did was opened up a whole new world with coronary angiography. And then they decided, well, how can we fix it? Well, one of the first things that was done was called myocardial poudrage. And what they did is they opened up the sternum, opened up the pericardium, and took a sponge or a gauze and roughened up the surface of the heart and poured talcum powder on it. And the thought was that the new blood vessels would grow in and revascularize. Well, that didn't work out too well. But then someone got the idea of, let's do this. Take the internal mammary, which originates from the left subclavian artery and can be taken down. And what they did was they took a probe and created a tunnel into the heart muscle and basically stuck the artery in it. Now, that sounds like it didn't work, but here is one 35 years later, and what you see here is the internal mammary coming down, and here's the left anterior descending, but there's actually growth of blood vessels. And I was fortunate being, I guess, old enough now, young enough then, to be able to study some of these, and they were all open. But now, here's where Ovid comes in. This is not Ovid, but he's standing by a man named Rene Favalero, who was a cardiac surgeon from Argentina who came up with the idea of doing a bypass operation. So that's what he did primarily at Cleveland, and this was his idea. This is the aorta coming out of the heart. Go back. Any rate, this is the aorta. There's a vein sewn in here, and you had to reverse the vein because of the valves that are in it, and then sewed it in to the artery on the heart where this was the lesion was. And later, they began using arterial conduits, which were much better. And knowing that I was going to do cardiology, my senior year in medical school, I did 3 months of cardiac surgery. And during that time, we did no bypass. Favalero did his first bypass in 1967, and what we did was we operated on children and early valve cases. I never saw a cabbage at that time. So then things began to change dramatically. But do you have to have surgery to fix this? I mean, there's got to be an easier way to do it. Well, this guy said no. And his name is Andreas Grunzig, and I first met Andreas in 1978 when he came to visit the University of Florida, and my chief locked us in a room with him for about 2 or 3 hours. And he explained what he had been working on, And then over the years, I saw him periodically. And unfortunately, at age 46, he was killed in a plane crash. Just a real loss. And at that time, under his tutelage, we formed the NIH steering committee to study this angioplasty to see if it worked. And what he did was he threaded a wire down through the coronary and then threaded a balloon over it, blew the balloon up, and then deflated it, and that would fix the lesion. I can tell you, the first one of these I did, I had diarrhea for a week before I did it, because that was scary, because you weren't supposed to put catheters down those arteries. But at any rate, we found that angioplasty wasn't working that well. 40% of these patients recurred. So then they got the bright idea of let's put a metal framework in there to keep the artery open. So the first one was the Gianturco-Rubin stent, and they were awful. Every one I ever studied with those, they were clotted off. But then this type of stent was developed, and it was miraculous. It dramatically reduced the necessity for surgery, and it worked out well. Some limitations with recurrence. And then in May of 1995, there were two individuals I know of that got one of these stents. One was Mother Teresa. That was done at Scripps, and the other one was me. But at any rate, and I also, a friend of mine told me that after the lab they did Mother Teresa's stent in, they never had a death in it afterwards. I was not that fortunate for those that followed me. But anyway, what you would do here was you threaded a catheter down, and over a wire, the stent was mounted on a balloon. You inflate the balloon, deflate it, and leave the stent. And this was working well, but particularly in diabetics, there was an increased incidence of recurrence, and bypass surgery was recommended more in that group. But we tried all kinds of things, some of them pretty rugged. This was a little device that you blew a balloon up and you pushed the plaque inside this, and then you spun it and cut it off. We also had one here. This was called the death machine by some people. This was a rotating diamond-covered burr that would spin at 100,000 revolutions per minute and would grind your way through it. But again, that didn't work out well as a standalone procedure. We also tried laser, and that really didn't work out that well. And then somebody got the idea. They used to use a drug in kidney transplants called sirolimus. And what they did is they started putting coated stents with sirolimus where it says medication, and that would prevent fibrous tissue from growing in and causing a recurrence. And we're still using some variation of that today. They even tried to do a bioabsorbable stent, but that didn't work out too well. Now, in 1912, James Herrick, who was a British physician, also described the first documented coronary thrombosis. And that's a term that gets thrown around a lot, but it basically means a clot in the artery. And then in 1973, cardiologists agreed that that was the problem, and that we needed to address it. And since we had gotten stents later, and we thought, well, we could do intervention, maybe on heart attacks. And what we would find is that over a period of years, here's a normal artery, plaque builds up, and finally the plaque ruptures. And that material that's inside is very thrombogenic, and clots form on it. And what happens is it shuts off blood, and that's a heart attack. Now, if these are angiograms, this is the right coronary artery, and you see a stream of dye, but see that negative image there? And here's the Widowmaker artery, and here you see a negative image there. Those are clots. And then this is the left coronary artery, and there's two things. One is you see clots in here, but you also see no flow down here. But after getting rid of the clot, you see there's excellent flow down there and no obstructive disease. And what we also found was that only about 50% of people with clots in their artery had a significant blockage. And it was because of the plaque rupture, not, and that's why so many heart attacks come on suddenly. I was at a meeting with a guy presenting some stuff. It was Peter Rentrop from Germany, with a very thick German accent, said, oh, it's very simple. You simply put a vial down, you shake it, you break up the clot, and it goes away, and everything is good. Well, the guy standing next to me turned to me and he said, we are never going to get a night's sleep the rest of our lives. And he was pretty right. We even got some little toys that would inject saline into the clot and then suck it out here. And sometimes that would get rid of it, but sometimes it would be such an overwhelming amount you couldn't do anything. But what's interesting is, if you look at 1950, the incidence of heart attacks was 307 per 100,000. Now it's 233 per 100,000. Why? Any idea? Statins? What else? Exercise, lack of smoking, awareness, and we got a new one now, GLP-1 inhibitors, because they actually decrease cardiovascular mortality, and nothing else in the treatment of diabetes does. And also, the mortality of heart attacks has dropped from 30% to 5%. And what you have to remember is, when a clot forms and blood is cut off, that one muscle starts to die. But also what happens is the heart becomes electrically unstable. And so what happens then is someone can just die suddenly. And most people that die from heart attacks, 60% or more, die because of the arrhythmia. So that means that when I had my heart attack, I drove myself to the hospital because I knew. And you don't do that. You call 911, and you get there as quick as you can for two reasons. One, you're more apt to die from arrhythmia, and secondly, you can save muscle the sooner you get in. And we used to measure what's called the door-to-balloon time, and that is from the time you walked in the ER door till the time we could have a catheter down the artery and a balloon in place, and that's how we measured efficacy. And there was a good correlation between survival, amount of damage, and getting in there quickly. Now, the other thing we have is electrical failure of the heart. it just stops. I remember my grandmother, they said, well, Grandma had another one of her spells where she just fell down in the kitchen, and so they took her to the hospital, and she had complete heart block. And so they had to put a pacemaker in. This was in 1964. But one of the interesting things is our family had to pool money to buy the pacemaker, and which they did. They also had to agree that if my grandmother died, they could take it out and put it in somebody else. And she did, and they did. So things have changed a bit. Now, this is a gentleman named Earl Bakken, and who was a bioengineer that invented one of the first external pacemakers. And this is that patient. Walt Lillihei put a pacing catheter in his artery. That's his pacemaker. I had the pleasure of having dinner with Earl Bakken one time, and he had started this little company you might see back there called Medtronic. And any rate, it was amazing to talk to him and how much things have progressed. Now, this is a standard EKG, and every time you see a heartbeat, electrically, there's a mechanical event following. This down here looks pretty chaotic, doesn't it? That's called ventricular fibrillation, and that's the cause of sudden death. Now, we decided there's something you can do about that. So this was the first defibrillator that was used, and then in 1947, a defibrillator is when you see people jump on the table in the ER from being shocked. That's what does it. But now we've progressed a lot to the smaller defibrillator here, but also, does anybody know what this is? It's an automated electrical defibrillator. And what you do is you put it on the chest, and it will tell you, give a shock or don't give a shock. And this is incredible. They're on airplanes. You see it in malls. You see it everywhere. And then we also now have implantable defibrillators. Now, how many people here know CPR? Everybody needs to know CPR. And if anybody doesn't, I would encourage you to do so. And it's probably saved over 100,000 lives a year. Now, another thing that came along is better imaging of the heart with a two-dimensional echo. And gives you, well, here's this, here's the left ventricle, the right ventricle. Here it is on ultrasound with the tricuspid valve, the mitral, left atrium, and right atrium. When I was at the University of Florida, we had 3 veterinary cardiologists that were in our group. And every Friday morning, we used to have to stand up and describe what we're seeing on the echo. It was brutal. You would be in a sweat. And I remember one of my fellows stood up there, and he was almost crying. He said, I don't know what this is. I've never seen anything like it. And one of the veterinarians spoke up and said, well, it's a python's heart. So eventually we learned. Now, is artificial intelligence new? No. When I was a fellow in Gainesville, there was a guy named Lamar Crevasse who had been working with one of the electrical engineers on campus to develop computer-read EKGs. And that worked out beautifully. We also had a calculator we used to use that would calculate cardiac risk, knowing your cholesterol to know whether or not to treat someone. And a big change was digital angiography. And spy satellites would go over a house and take a picture. They would come back the next day and take a picture and subtract yesterday's picture from today's, and they would see the only thing left was a truck. That's called digital subtraction. And that is how we wound up getting such good resolution on our film now. Now, let's talk a little bit more about AI. There are some places where AI is very beneficial, particularly if you look at automated image acquisition. If you're doing an intracoronary ultrasound, it can get rid of artifacts and give you a much better picture and even tell you the exact diameter of the artery so you know which size stent to put in. It's amazing how that has helped, but it still needs to be looked at. And another issue is AI uses opaque logic, and that is that we don't know how it gave you an answer, and which leads to a lot of other problems. And but also one of the great things, keep slipping over. One of the great things in medicine is the advent of randomized clinical trials to identify what procedure might work best, higher success rate, lower mortality. That information cannot be gleaned from raw data. It takes a specific study. So to me, the future of cardiology is going to be in humans understanding the mechanism of how things happen and then working around it. And I remember a patient years ago that I cathed, had a total occlusion of the Whittle artery. I couldn't get a wire through it. So I sat there and talked to him. And I said, you know, the one thing you don't have to worry about is you'll never have a heart attack. Well, about 2 or 3 hours later, he started having a heart attack. We sent him to the OR and did a bypass, and he did fine. But it also made me understand we don't know squat. And what we think we know makes us feel better, but we don't know everything. And another issue is the bias. In the early studies that were done, women were eliminated from being eligible for study. And one of the reasons, a logical reason, was that men had a higher incidence of coronary disease. And if they studied that population, they could get results quicker. But women were excluded, so I said, well, it's obvious. Women don't have heart attacks because they've got estrogen. And so then we had that thing that went on for years. Then we had the HERS trial, which was a double-blind study that showed more where things lie. And these things cannot be picked up at this point by AI. And that's why I think it's still going to take a rational human overlooking it, and we need to know more about what we're doing and how it happens before we can do anything. I think what I'm going to do, I had a little bit more, but I'm going to stop here and see if anybody has any questions. Yeah.
All right, we'll have questions here.
Yeah.
Yes, I have a pacemaker, and that device over there, if I somehow fall on the ground, can they put that on me? Can you do that device with someone with a pacemaker or a defibrillator?
Yes. With a standard defibrillator, you can see the waveforms. this will analyze those waveforms and can detect if your heart stopped from fibrillation, there will be pacing spikes, but the fibrillation can still be seen. So yes, it will still work.
Does EDTA have any place in the kinds of things you're talking about?
To stay in its package.
Okay, thank you.
Yeah. Sorry.
Thank you, doctor. Are there any other questions?
Oh, yeah, EDTA doesn't do anything. EDTA is a calcium binder. And what people thought was, well, these arteries are full of calcium, so EDTA will just suck it out. And no, doesn't work.
Yes, yeah.
This is not a question. I'm completely ignorant of my body. I want to congratulate you on a wonderful talk.
Thank you.
Yes,
I appreciate it.
this is a little bit off the track of what we normally